Are you sitting at home right now with a negative pregnancy test in your hand after another unsuccessful embryo transfer? My name is Brandis Montez, and I'm a fertility nurse practitioner with over 5,000 embryo transfers under my belt. Not only do I do these every day, but I do these follow up talks all the time. So let's have one right now for free. There's a couple of things I think about when I think of an unsuccessful embryo transfer. So don't think of this as a failure. Think of it as we're collecting data to help get you closer to having a baby. So let me run you through my mind of what I think about when we have an unsuccessful embryo transfer. The first thing is, what was the type of embryo you transferred? Was it a day three embryo? Was it a blastocyst embryo? Was it a PGTA tested embryo, meaning you tested it and made sure the chromosomes were normal? And the other thing is, how old were you when these eggs were retrieved to make this embryo? Now, if you have an untested blastocyst embryo, again, this largely depends on your age on when the eggs were retrieved. I'm going to put kind of a little thing up here in the corner so that you can see these success rates. Make sure to screenshot these. These are not cumulative. This is just per embryo transfer. And this has to do, again, at when the eggs were retrieved, not when you're transferring. Day threes give us a little less information, so it's harder to kind of pinpoint what's wrong, which is usually why I'm a fan of growing to blast. That's a conversation for a whole other time. However, day threes are kind of harder to know because we don't have more information. Would they have made it to that blastocyst stage? We don't know. If it was a PGTA tested embryo, meaning you did preconception genetic testing for aneuploidy, which is where we take a biopsy of a blastocyst embryo and we send it to a lab, we'll get a report back telling us the sex of the embryo and if that embryo was chromosomally normal or abnormal. If it was normal, or what we call a euploid embryo, then the live birth rate is 65% on that first embryo transfer, 88% on the second embryo transfer, and 95% on the third embryo transfer. So normally I like to have my patients bank 2 to 3 normals per child they want before moving on to transfers. That way we have embryos banked. The other thing I look at is your uterine lining. How thick was it before we started you on progesterone? Did we at least get it to 7 millimeters? Was it trilaminar? I also compare this to what your lining looked like at the time of trigger before an egg retrieval. I like to use this as a comparison to see what we should be aiming for and maybe what's not attainable. Overall, the goal for a lining is 7 millimeters and trilaminar before starting you on progesterone. If you had problems with the lining and you did a medicated embryo transfer, I may switch you over to a natural or a modified natural. Maybe your lining just responds better to your own hormones instead of a medicated, and vice versa. So if you had issues with lining getting it thick enough or having fluid in the lining, now I start to think about, should we change the protocol? If lining was okay, then you may not need a protocol change. The other thing I look at is your thyroid levels. Is TSH where we want it to be? I typically keep people between zero point 0.5 to 2.5 TSH level. There are studies that show as long as you're in a normal range, that's okay too. So there's no really right or wrong way. The other thing I look at is thyroid antibodies. Same kind of thought. If your antibodies are high, but your TSH is normal, some people treat it. I like to. You don't have to. There's no right or wrong way here. Now, if all of these things check out, usually and most often, the problem is just the embryo, even if it's a euploid embryo, because we know that it can take up to 3 to get a live birth. Now, if you're sitting in a position where you've had 3 failed chromosomally normal or euploid embryo transfers, it makes me more want to actually do a hysteroscopy and put a camera in the uterus to make sure that nothing subtle is being missed that maybe could have even been missed by a saline sonogram. The other thing I start to think about is silent endometriosis or even just endometriosis that hasn't been diagnosed. Do you have super painful periods that causes you to miss plans? Do you have pain with intercourse when there is deep penetration? Do you have GI or urinary symptoms that come accompanied with your period? Do you have a first degree relative, so a mom, a sister with endometriosis? That means you are 6 to 7 times more likely to have endometriosis. And so I'm not doing a biopsy or a laparoscopy to check for this. Usually I'm just going to suppress you with 60 days of Lupron or Alyssa or Myfembry before a medicated next embryo transfer. The other thing I think about is a biopsy of your uterus for something called CD138. CD138 is where we check for plasma cells that can be associated with chronic endometritis, which is just chronic inflammation of the uterus. And so we typically treat this with 2 weeks of doxycycline, can be adjusted if you have allergies. Do you have autoimmune issues, chronic illness, or some sort of other inflammation going on in the body? We can use different immune protocols to try and target these things, although these things are less studied. The other thing I think of is blood clotting disorders. Is there something that, hasn't been caught that maybe you need to be on aspirin or Lovenox for? Now, a lot of these deeper things are more for people that have recurrent implantation failure, meaning that you've had 3 unsuccessful euploid or chromosomally normal embryo transfers. If you've only had 1 or 2 embryo transfers and your lining was thick enough, your thyroid looks good, and you've had a uterine evaluation within the last 6 to 12 months, chances are it was likely the embryo. These are just a few things that I look at off the top of my head when I have someone come to me after an unsuccessful or several failed unsuccessful embryo transfers. You need to make sure that your provider is going through your IVF history, cycle history, pregnancy history to maybe come up with some solutions and things to start testing for that are right for you. But hopefully, this video helps you to start advocating for yourself and gives you some things to think about in the meantime while you're waiting for your follow up.